Dr. Saad. Thank you for the kind introduction. Dr. Mohammed Zbaid and Dr. Fahad, Dr. Abdullah, thank you for the kind invitation. I congratulate you for this great meeting, and I think it's one of the things that we need in Kuwait is having a yearly update in cardiology. We are lucky in cardiology, we have a lot of evidence is moving very quickly, so we have to do this very frequently. I'm trying to replicate what Dr. Zbaid did by wasting time until they get things ready. So I hope we are almost there. So I'd like to thank Dr. Mohammed Shamsa for setting the stage for me, because I'll be talking about cardiogenic shock and partly about the shock team that you mentioned. So are we ready, guys? Okay, good. So I have no disclosures. These are the objectives of my talk. We're going to talk about the definition of cardiogenic shock, both from clinical standpoint and from hemodynamic standpoint. We're going to talk about the recent classification for cardiogenic shock. We're going to talk about what options we have to treat these patients. We're going to talk about our cardiogenic shock protocol at the Chest Diseases Hospital with our shock team that we've established a few years back. And I tried to make this talk very practical talk, so we'll show lots of case examples. Okay, so what is cardiogenic shock? So shock is when the cardiovascular system is unable to meet the demands of the vital organs. And when we say cardiogenic shock, means the problem is with the heart, not able to provide enough cardiac outputs. So this is from a basic understanding of what that means. But from a hemodynamic standpoint, the definition used in many trials is having a systolic blood pressure that's lower than 90 for at least 30 minutes, or you needing to put patient on pressors to bring the systolic blood pressure above 90, with evidence of end organ hypoperfusion. That could be a patient that's not fully awake, or evidence of elevated lactate, or evidence of acute kidney injury, and reduced cardiac output, but also importantly, a wedge pressure that is elevated, okay? So cardiogenic shock complicates 5 to 10% of acute MI. It's more frequent in ST elevation MI for obvious reasons. And despite all the advances that we have in medicine, pharmacologically, from mechanical circulatory support, mortality of cardiogenic shock continues to be elevated at 50%. So what are the hemodynamic of cardiogenic shock? So these are, they look complex. They're pressure volume loops. On the left-hand side, it's what you expect from normal heart. In B is in the middle is when you have acute MI. And with that line, which is red and then becomes blue, that's a reflection of reduced contractility. And the reduced contractility leads to a reduced stroke volume. And in C, you can see the severe reduction of cardiac contractility and elevated end diastolic pressure that leads to a very small space. And that suggests that stroke volume is really, really low. And that's when the patient goes into shock. This is very important to understand when you manage these patients. This is the most recent cardiogenic shock classification brought by Sky. So the basis for this was to classify patients to make it easier to study cardiogenic shock. That's the main reason for this, because the trials in cardiogenic shock are very difficult because the different stages of cardiogenic shock are not the same. So a patient in cardiogenic shock stage B is not the same as someone who is in class D. So you cannot compare these two patients. But I find it also helpful practically to use this classification because it tells you the amount of support you need to give the patient. So a patient in class A, which is at risk, so they are not in cardiogenic shock, but they're probably in sinus tachycardia with a heart rate of 120. You know that patient can go into cardiogenic shock. You might treat them with some pharmacological intervention. Class B, maybe you can use a balloon pump. Class C, maybe use impeller. Class D and E, this is a situation where you want to use VA ECMO, for example. So it can be helpful both from speaking among colleagues and describing the patient, and also telling you what kind of support the patient needs. This is my personal understanding of the way I think of cardiogenic shock. So when the cardiogenic shock starts, you have reduced contractility. That's after a patient gets a hit with acute MI. Following that, you have an elevation in diastolic pressure. This is followed by reduction in cardiac output that leads to reduction in mean arterial pressure. And what the body does, it vasoconstrict. So you have increased systemic vascular resistance. If this continues without any intervention, the patient's mixed venous saturation gets down because the oxygen delivery to the tissues is reduced. And this is followed by lactic acidosis, so the lactate starts going up. And now you're shifting from a hemodynamic shock to a metabolic shock. And ultimately, a patient develops acute kidney injury, multi-organ failure, and many times they die eventually. So to simplify this, cardiogenic shock, it starts with a hemodynamic derangement. And that's a perfect time for intervention because most of the tools that we have, they can help you with the hemodynamics. But if you wait long enough and it becomes a metabolic shock where the patient is already in heart failure, in acute kidney injury, lactic acidosis, DIC, you've probably missed the boat. And it's the wrong time to start this patient on support, mechanical support, because you missed your chance. The patient probably is not going to do well anyway. So early recognition, it will help you use tools that can reverse hemodynamic derangements before the patient becomes an overt multi-organ failure where the prognosis is poor regardless of what you do. So if you use any intervention in a patient who is in end-stage shock, the patient is not going to do well, and you're going to say, well, this intervention doesn't work. It's not it doesn't work, you're just using it too late. So what are the therapeutic options? Now, you have a patient with cardiogenic shock. What options do we have to treat them? Well, we have the pharmacological therapies, including inotropes and pressors. And I'd like to differentiate between these. And you cannot believe how many people mix between pressors and inotropes. They treat them the same. And here I want to highlight one point. What I see many people do is a patient becomes hypotensive. You put them on pressors. The blood pressure gets better. High fives. We are happy. We've managed the patient. He's good. That's not right. Because I've shown you that when a patient becomes in shock, the normal response is that you develop vasoconstriction, your systemic vascular resistance goes up. So when you give them pressors, you just make them even more vasoconstriction. So the way I want you to think about vasopressors is it buys you time for you to deal with the underlying problem. It's not going to solve the problem. It's just going to temporarily increase your blood pressure until you solve the problem. The other options we have is mechanical circulatory support, like Dr. Shamsa showed the options we have. And you have to treat the underlying problem and all the supportive care with treating DIC, ventilation, and so forth, and antibiotics to treat infection. So these are the options that we have available in Kuwait. From the left-hand side is the balloon pump. In the middle, we have the Impella. So it's an axial form of pumps. And we have ECMOs, which are centrifugal pumps. Okay? But when you think about mechanical circulatory support, this is the way I think of it. These are the main basic things that gives you from mechanical support. So if we think about balloon pump, for example, does it give me circulatory support? It gives you a minimal circulatory support. It gives you maximum 500 cc's of cardiac output. So if you think of a normal cardiac output in a stable patient of 5 liters, the balloon pump is going to give you half a liter. So don't expect too much from circulatory support of the balloon pump in terms of giving you cardiac output. And bear in mind that the worse the LV function, the less support you get from the balloon pump, because it's a counter pulsation. So wherever you push forward, it will gonna push it back. So the worse the patient, the less support you get. Ventricular unloading, it's very good for ventricular unloading. So it takes away the pressure from the heart. So it's an effective tool for that. And I think it's a really good tool for improving coronary perfusion because it increases the diastolic pressure, which is the time for coronary perfusion. If you think about ECMO, for example, it gives you great circulatory support. We can give you 4 or 5 liters, right? But it's really bad for ventricular unloading unless you put it through axillary artery because it's ejecting blood against the heart. And it's, in that sense, it worsens your ischemia. So management of cardiogenic shock is a very complex one because it's not a STEMI where you put a stent and you're done. It's not a procedure-based management because these patients get treated, they are in CCU for a prolonged period of times. You need to have an organized approach to managing these patients and you need to develop a shock team like Dr. Mohammed Shamsa showed. And he also nicely illustrated this slide, so I don't want to belabor the point, but the bottom line, if you have a shock team, your outcomes are better. You're going to manage the patient better. You're going to use more wedge catheters, and you're going to use more circulatory support in the right setting and use them earlier than later. So I remember 4 years ago, I think 6 months after I started my intervention work at Chest Disease Hospital, I was called for a patient in the ward. And that's how the whole shock team started. Because the patient was I still remember him, he was 46 years old, multi-vessel disease, presented with NSTEMI, and now awaiting CABG. And they called me, he's not feeling well, chest pain. By the time I went to the ward, the patient arrested in the ward. So at that time, I just reverted to my autopilot, and I said, we are doing CPR. So talking about eCPR, I said, get me ECMO. And I don't know how they listened, because I didn't have authority over the perfusionist or anyone, but the patient is arresting, people are doing CPR, so whatever you order, they're gonna give it to you. Anyways, we got the perfusionist there. I put that patient on ECMO, and then we took him down to the cath lab. I did multi-vessel PCI, put ECMO, I put ECMO in the ward, and then put Impella to unload the ventricle, because I told you the ECMO doesn't load the ventricle. And we did multi-vessel PCI, and then we took him to the CCU. So I was following this patient daily basis, and now you can see the difficulties, the problems of bleeding, the thrombocytopenia that you have this patient because you have two circulatory support machines, you are antiplatelets, how are you going to remove the ECMO, the interaction between us as cardiology with the cardiac surgeon, because before that patient, ECMO was managed completely by the cardiac surgeons. So that was very unusual intervention from our side. But thankfully, and I take this stage to thank Dr. Jamal Fadlibi, who is the head of our cardiac surgery. I sat down with him and I said to him, listen, we have to put ECMO for our patients because they arrest in front of our eyes. By the time you guys come, we lose the golden first 10 minutes before the patient is on ECMO. And we've created some agreement that helps our patients. So this is the birth of our cardiogenic shock 4 years ago. And these are the things that we have in our current protocol in terms of the diagnosis, the cardiogenic shock, what to do. You have to inform the shock team. You have to do echo to specifically rule out LV thrombus, because if you put Impella, there will be, if there's LV thrombus, you create a stroke. If you have a shock, my rule in the CCU, you have to put a wedge catheter. And in the middle, you see that how to differentiate between LV dominant shock, RV dominant shock, or biventricular shock. We'll show you some case examples. This is daily assessment. All of these came from that first case that we managed, and we learned so many from. So now we're going to move to a practical approach, show you some cases. And chairman, co-chairman, you can stop me at any time because I have maybe 5 cases, but they are short cases, I promise. So the first case is a 58-year-old male who was transferred to chest disease hospital from a different hospital with a diagnosis of severe LV systolic dysfunction and heart failure. So he was admitted with decompensated heart failure and organ hypoperfusion with rising lactate. Okay, so that hospital knows that we have a shock team, so they wanted to provide the patient with a better care, so we accepted that patient. Without too many details, as I told you, if you have, in our rule in our CCU, if patient in shock, invasive hemodynamic assessment is paramount. Otherwise, you're driving with your eyes closed, okay? So these are pictures from my WhatsApp, because the cardiologist and the CCU is sending me the data. So this is the data we got from the SWAN. And the bottom, on the top left, you can see the cardiac output is reduced at 2.4. And you can see cardiac index is really low at 1.2. Remember, we said cardiogenic shock is the one less than 2.2. This is 1.2. So severe reduction in cardiac output. Okay? And these are some of the parameters we also get. I want to get your attention to the systemic vascular resistance. This is extremely elevated. So normal is around 800, 900. Okay, if you're used to using Woods, you can divide by 80 and you get your Woods number. But the systemic vascular resistance is extremely elevated. The stroke volume, which is expected to be around 75 cc's, is severely reduced to 28 cc's. So every time the heart is beating, it's only ejecting 28 mils of blood, so nothing. But these data helped me to think about what's going on, because the doctor called me and said, okay, let's put him, his pressure is soft, let's put him on pressors. And I said, no, we cannot, because his systemic vascular resistance is already double normal. So let's put him on, okay, so these are the options: pressors, inotropes, balloon pump, Impella, ECMO. So at that time, I thought using inotropes can be effective in this case. So what I said, let's use the butamine. I started with really low dose, 2.5, because it will give us some increase in contractility potentially, and also will reduce systemic vascular resistance. But I told him have the levo ready because the patient may become really hypotensive, okay? So look what happens less than 2 hours after. We repeated the numbers. Look what happens. Cardiac index, which was 1.2, became 2.4, double, okay? Cardiac output doubled, okay? And look at the numbers here. Systemic vascular resistance went down by half. Look at the stroke volume, almost tripled or doubled and a half. So this is like almost like exact science. You reduce systemic vascular resistance, everything went up. So that was all the patient needed. After that, we transitioned him from dobutamine to digoxin. We loaded him with IV digoxin, and then we transitioned him to oral digoxin, and he did well and discharged home. Without mechanical support, just by understanding the hemodynamics. So the point of this, to highlight two things. One is the importance of invasive hemodynamics, because it will tell you what the body needs for you to intervene. Two, that not all patients with cardiogenic shock need mechanical circulatory support, okay? So that's case number one. Case number two, this is a case I did 3 months ago, 63-year-old, all the risk factors. He had multivessel PCI in Turkey about a year or year and a half prior to presentation. So he presented to a different hospital with high-risk NSTEMI, and back to Dr. Abdullah Ismail's presentation, not every NSTEMI is a simple NSTEMI. This is a high risk because the patient was having recurrent VT, recurrent VF, multiple shocks. So this is someone you treat like a STEMI. So I took him to the cath lab, injected the right, looks fine, injected the left, and he has occluded both the LAD and LCX. And these are the vessels where he had the stents put in. So at that point, I'm thinking, okay, what's going on? Which one is the culprit? Is there one that's already, because it's very unusual to have two arteries occlude at the same time. Meanwhile, the patient is becoming more hypotensive. I'm shocking him, giving him pressors. It's a very dynamic situation. So I said, you know what? I'm going to wire both vessels and see if they open. If it's a thrombus, probably the wire will go very easily. So I was able to wire both. This is after I did some ballooning. I get some flow. The patient now is in VT, VF. I'm shocking him, going up on pressors. I said, listen, I'm not going to be able to finish this case unless I need to put the patient on mechanical support. So the next step, I'm putting an impella in. Okay, so put the impella in, and now I am able to stent both vessels and open the vessels. And after, it's interesting, after they put the impella, the patient rhythm-wise became very stable. No recurrent VT, no recurrent VF. He did very well in the hospital. Unfortunately, he had a small stroke. He was aphasic, but that improved toward the end of the hospital stay. But this is to highlight that invasive mechanical circulatory support is associated with some risk. So our initial shock team protocol, begets a lot of other protocols. So protocols for anticoagulation, protocols for weaning. We all developed this after we initiated our shock team. But he was discharged home in good health, and his aphasia improved significantly. Okay, so case number 3. 45 years old, no known past medical history. He presented with acute shortness of breath. Long story short, it's a late presentation STEMI. He was hemodynamically unstable, requiring high doses of pressors. He was on levofed 0.4, adrenaline 0.4, systolic barely 70, and he was transferred. I still remember I was cathing him at 11 p.m. This is really important. But this is the echo I was getting from that referring hospital through WhatsApp, and showing us a very interesting finding there. So what he has partial rupture of his papillary muscle. And for the echocardiographers here, you'll know better than I do, but the color is not very impressive of severe MR. And this is what you expect in acute MR. The color, don't expect it to be huge, because the LA pressure is extremely elevated. So you're not gonna get a high or a very impressive color. So we get the patient. The first thing I did, I put him on Impella to stabilize him. And then after I put him on Impella, I called Dr. Jamal, which is our head of cardiac surgery, and the patient was in the OR 10 a.m. the next day. He got his mitral, this is his coronary, he had an occluded circ, his RCO is fine, and this is very unusual, by the way, because if you have occluded circ, usually you don't get papillary muscle rupture because of the dual supply of the papillary muscle, but it usually gets it with the RCA. It happened in this case. He was taken to the OR 10 a.m. So this case was 11 p.m. the night before I put the Impella. After I put the Impella, even the patient's face changed. He became more comfortable. The next morning, 10 a.m., Jamal took him to the OR. This is a high risk. These patients' mortality is 80% with intervention. put a mechanical mitral valve in. They removed the impella in the OR. At the end of surgery, they noticed that the leg where the impella was in is now ischemic. So I go to the OR, I see the leg, the Doppler, there's no color. So what probably happened is so the way they removed the impella, they put compression on the axis, probably some thrombus went down. So I took him, I said, look, I'm gonna take him to the cath lab. So I took him from the OR to the cath lab. I inject, in the right-hand side is the SFA, the superficial femoral artery, and you can see it's full of thrombus. Anyways, we crossed, we did some ballooning, and we got good flow back to his leg, and all he did anticoagulation, and he was discharged home in good health. So this is someone who presented with a mechanical complication that's associated with 80% mortality, doing well, because early recognition of the problem, quick mechanical support, and quick surgical intervention. Case number 4. 60-year-old smoker, late presentation, anterior STEMI, clinically unwell, with hypotension requiring pressors. This is actually from Dar Shifa Hospital, Dr. Saad. You know this patient probably. Anyway, so they diagnosed him nicely with a ventricular septal rupture. We do the cath. He has occluded LAD. Otherwise, his circ and RCA are fine. This is the picture on the left-hand side for the echocardiographer. This is LAO cranial. So this simulates a 4-chamber view. So you clearly see there's injecting in the LV, and you see some contrast going to the left side. That's the RV. So he does have ventricular septal rupture. So we put an impella. But here, we are not going to send the patient to the OR the same day or the next morning like we did with the papillary muscle rupture. This is a very difficult situation to treat surgically because they will not be able to suture a patch on the VSD. So what we did, we kept the patient for, the surgeons want to keep them forever because they want the tissues to heal. And we are pushing in the other direction. So this patient stayed in CCU for about 10 days. Troponin went down, and then the patient was taken to surgery, and he did really well. He was discharged home after a week from his surgery. Case number 5, 52-year-old anterior MI shock with severe MR. This is different from the other patient I showed you because this patient is multiple comorbidities, not a surgical patient. So we managed this patient differently. This is his anatomy. We opened his RCA, but the patient continues to be unwell in shock because of the severe mitral regurgitation, ischemic mitral regurgitation. So what we did, we put an impella in, and as I told you, he's not a surgical candidate, so what we did mitral clip for him with the impella in place. And this is, by that time, there was only 10 cases worldwide that's been done that way to save a patient. And we did 2 cases in our institution. One of them, this one did really well. The other one did well initially, but the clip, because we used a bigger clip, because the clips comes different sizes, perforated the leaflet about a month later. But that time the patient was more surgical candidate, so he was taken to the OR and he had mitral valve replacement. But from that case, we learned that in these cases, we use a smaller mitral clip, so not to perforate the mitral valve. And then we went up, we did CTO, a PCI of the LAD, and he had complete revascularization. Okay, last case is a 44-year-old gentleman presented with inferior STEMI, transferred to our hospital with cardiogenic shock, acute kidney injury. You can see a balloon pump in place. He has multivessel disease, occluded LAD, that's probably a CTO, and this is the culprit. This is done by my colleague, Dr. Musa Akbar, Dr. Ahmed Imam. So they put an impella in because he was in balloon pump, but he was really hypotensive. And they did a great PCI of the RCA, they did great PCI of the circ, and they left the LAD for a later stage. So I got involved in the case the next morning. The next morning, this is a young person, he's 45, he got revascularized, he's on impella CP, but he is still in severe shock despite good mechanical support of the left system and good pharmacological therapy. His kidney function is worsening. Now he's on dialysis. His EF is 20%. We did bedside echo, and that highlights the importance of doing echo on these sick patients. His RV was ballooned out. It's barely moving. So, and you can see that with the inferior STEMI with the RCA, you get RV infarction. So if you have severe RV infarction, no matter how support you give to the left system, the patient will be in shock. And I still remember his mixed venous saturation was 28%. So what we did, I took him back to the cath lab the next morning, and I put an Impella RP to support his RV. And look what happens after we put the Impella. This is a patient in our CCU with the two Impellas side by side. And this is 1 day after we put the Impella. The CVP went down from 15 to 10. His mixed venous saturation, I told you 28%, 30% improved to 55. His cardiac index improved. PAPI is something we use to assess RV function for hemodynamics. It's a pulmonary artery pulsatility index. If it's less than 1, it means RV is failing. So it was 0.7 and improved to 1.3. Lactate was not extremely high anyways by that time. And he was in shocked liver as well because of the RV infarction. And his liver enzymes were in thousands club. Patient did well. After 6 days of support, we removed both ECMOs. Pressors were removed. He was started on hydralazine nitrate because his kidney injury. He was on dialysis, and digoxin was started for support. Hospital stay was 1 month. So these patients are very intensive on healthcare. They need a lot of care. His kidney function recovered. He is off dialysis, as well as his liver biochemistry. So in conclusion, as these cases show, cardiogenic shock is a very bad disease with a very poor prognosis and continues to have 50% mortality. It's very paramount for us to diagnose them early and manage them early, not wait for them to reach the end of the tunnel. Shock team is essential to managing these patients. It's very important. And you need, as institutions, to develop your own protocols and modify them over time to provide better care for these patients. And mechanical circulatory support play an important role, but has to be inserted by people with expertise in terms of patient selection and as well as from access standpoint. And thank